Okay, class, welcome back. In this unit, we'll be covering the complete blood count, right, or CBCs. You'll see it referred to in the chart and in just communication between other providers. So the CBC includes the hemoglobin, hematocrit, platelets, and white blood cells. These old diagrams you used to see back in old handwritten notes. You may see them in still like in the electronic medical record. They may use this layout. But typically, most lab values now are down in like columns and charts, typically with a reference value next to it. So this is just a shorthand to kind of give you an idea of what these values are. But you may see it, you may not, but let's move on. So the first thing we'll cover are white blood cells. Now, again, we're not going to spend too much time getting into specifics because you guys know what white blood cells are, you know what red blood cells are, and so on and so forth. And again, the specific values, right, we're moving beyond just this hard line. So we're going to spend more time on the reasoning aspects. So normal values for white blood cells are anywhere between 5 to 10 times 10 to the liter. You may see different units. Again, every single facility will have slightly different labs and slightly different, normative values, just making sure you always compare what the patient has to that reference. This is from our acute care academy, and even in those guidelines, which again are guide practice, they don't dictate practice, they mention this point as well. Leukocytosis is exactly as you think it is. There's more or an increased number of white blood cells. We can have different types of it. Neutrophilia, when we have more neutrophils, pretty common. After a bacterial infection, eosinophilia. We've got, more eosinophils. Lymphocytosis, we see more lymphocytes, right? So different types of white blood cells can be increased, which can give us an indication of maybe what's driving this leukocytosis, right? Key thing to bear in mind that leukocytosis can occur, from a multitude of different things. It can be due to a surgery, right? It can be due to an infection. It can be due to trauma, right? So there typically really is no hard, upper limit or cutoff score. We factor in other things as well, whether or not they have a fever and other signs that may suggest infection. But just as an example, following surgery, which surgery again is basically controlled trauma, we can see values increase by about 3,000, right, or 3 on this scale, over the first 2 days. So typically, again, like the first 2 days after a major surgery, like we may see this value increase by about 3, right? That again will influence the value. So don't just take, again, just everything. Don't take white blood cells or any lab value just by the number alone. Factor in other things. Leukopenia, which is a lower number of white blood cells. So leuko, again, white, penia, low white blood cells, can be due to bone marrow failure, because again, all these things are produced in the bone marrow, radiation, chemo, HIV, and other viral diseases. And again, we've got guidelines for both. So, we factor in different symptoms and other clinical presentations. Patients with leukocytosis may have a little bit of a fever, may have a little bit of lethargy, maybe a little dizzy, maybe have some inflamed joints, right? Depending on what's driving it. You'll see this phrase used often within our lecture, and it comes right from the guidelines, using a systems-based approach, right? Not just relying on just this value to determine whether a patient's appropriate. Factor in other things. If the patient is, unstable, or maybe has a blood pressure or heart rate or other things that are, maybe make you think this patient's not appropriate, or maybe there's an infection that you're concerned about, right? Reason through it, determine if this patient's appropriate or not. Leukopenia is where we get a little bit more concerned, because this means the patients may not be able to tolerate if they get an infection. Hospitals are riddled with all types of different bugs and organisms, so we have to be cautious of this. They will have similar symptoms, maybe a little lethargic, fatigued. They may be a little short of breath, a little weak. If they have a fever, this is when we get a little bit more concerned too, because again, with low white blood cells, a fever, maybe they have an infection and they're just not really able to even fight it. And then, with the stress of exercise, may be a little bit too much for them. But even with that, still symptoms-based approach, right? We factor in other things, but just be cautious, especially if they have a fever, and especially if they are at levels below 1.5, which we would call neutropenia. You'll typically have an institutional policy for neutropenia and what's appropriate for those patients with very, very, very low white blood cell counts. All right. And in the next part, red blood cell counts, we've got our normative values here. Obviously, red blood cells carry oxygen and remove CO2 from our biological tissues. Causes for a decrease. Someone could be malnourished, have anemia, blood loss, which we'll see often after surgery, increases, dehydration, which would create more of a relative polycythemia. Could see it with COPD as well, with smoking. Again, we have our normal values here. Just like everything else, we'll follow that symptoms-based approach. There really isn't a hard cutoff for a red blood cell count. Again, we still use that systems-based approach. So we'll move on to our next value, hemoglobin, right? So this is one that a lot of PTs will use. We'll look at first when we're reviewing a chart, hemoglobin and hematocrit. We'll get into the hematocrit in a bit. Again, hemoglobin is that protein which helps bond oxygen within red blood cells. If you have too little of it, we're going to have some problems maybe delivering oxygen, right? So we can see decreases due to anemia, blood loss, like we can see after surgery, and iron or B12 deficiency, which are substrates which we need to produce hemoglobin. Causes for increase, again, polycythemia, similar causes that we would see increasing red blood cell count. This could be also relative polycythemia if the patient comes in dehydrated. Now, we have normal ranges. Again, always think of the demographics. Men typically have a slightly higher hemoglobin than women. Typically, though, we should see any ranges somewhere above 14 for both. That's about a normal range for both. Now, there, of course, are situations where we can have low values, right? So typically we get more concerned and more frequently you'll encounter when hemoglobin values are low. And we start getting really particularly concerned when values go below 8. After surgery, even though we said normal values for hemoglobin generally around 12 to 14-ish, right? Depending on for women, and then I think we said 14 to 17 for men, right? After surgery, it's not uncommon to see people in 10, 9, 8-ish after a procedure. There's some blood loss or some surgery. We only start getting kind of concerned when it goes below 8. Now, back in the day, the old guidelines were if you were below 8, you're holding therapy. The more updated guidelines reflect the same thing, system-based approach. Maybe that patient, again, has a hemoglobin of 8 or 7.8, but they're completely fine. They're asymptomatic. Their blood pressure is stable. Everything else is stable. And maybe they came in with a hemoglobin of 8.1. Maybe that's their normal, right? So we factor in other things. We're going to monitor vitals, monitor pulse oximetry, especially during exercise, because we know how hemoglobin influences our values. The old guidelines were again based around 8. Now we're in terms of cutoffs, we start thinking maybe more about cutting things off from a hard line for critical values, which would be below 7, which is where typically a lot of patients maybe get transfused, right? So if you go below 7, we call that a critical anemia. And then we get also concerned with values above 20. That would be pretty significant polycythemia, which would increase the risk for blood clots. So just be mindful of that. Again, patients, even if they are at 8 or slightly above, may have slightly decreased endurance, tolerance, activity, maybe a little tachycardic. That's why it's so important to manage. But again, no hard cutoff like we used to have for old guidelines. I included in the notes just like things that you might want to think about working with based on the old guidelines. But again, systems-based approach, reason through it, factor in other information. For example, like for patients with certain hematological and oncological disorders, there may actually not be a threshold for that patient. So again, it's a little bit more nuanced that approaching these lab values that we have before in the past. Hematocrit, again, it's percent of volume of red blood cells in the blood, in whole blood. Again, blood is a solution. Similar thing, men will have slightly higher values. Typically, most people should be around, you can think 40%, right, of whole blood should be of red blood cells. Values will slightly decrease in the elderly. We can have lower amounts or higher amounts. Lower amounts we call anemia. Higher amounts, again, polycythemia. Similar causes that we would see lower hemoglobin and red blood cells as we would see hematocrit, because hematocrit is a percentage, right? Not the number, the percentage of red blood cells in whole blood. That's why we typically look at this more often. Now, same thing, we have low critical values and high critical values for this as well. Low critical values could lead, could be situations where they have cardiac failure or high risk for mortality. High critical values, a high risk for spontaneous blood clotting because the blood is just super thick, right? So again, think of blood as a solution. If we don't have enough water or plasma in the blood, that's a really thick blood, and the thicker it gets, the more likely it is you might have a spontaneous clot. So clinical decision-making for anemia, same thing. Sorry about that. Same thing, systems-based approach. We look at this when patients get below 25. Again, similar to hemoglobin, normal hematocrit's right around 40%. But after surgery, it's not uncommon to have a slight reduction. We only start getting into considering whether a patient's appropriate or not if we start seeing it go below that 25%. Back in the day, that used to be 25% or below. That was a hold. Right now, again, we factor in other information. What's the heart rate? What's the pulse ox? What's their disposition? Again, understanding the patient may have some orthostasis, being able to monitor those things throughout the course of rehab. Again, we're using more of a traffic light versus a stop sign. For polycythemia, same thing. Again, we have those critical values, again above 60. Kind of rare for this to be that high. You're more likely to see an anemia in an acute care setting, but it's possible to have polycythemia. Same thing, systems-based approach, determining patients are appropriate or not, because again, that risk for clotting. Platelets, again, the other part of the CBC, which we know are important for stopping bleeding or hemostasis. Normal range, 150 to about 350. Thrombocytosis, again, too many platelets. We can see this with iron deficiency, cancer, inflammation. Thrombocytopenia, again, thrombosis, cyto, clot, cell, penia, lower amounts, less than 150. We can see this with chemotherapy, radiation, certain infections, and liver disease. For thrombocytosis, we have too many platelets. Again, systems-based approach, factor in other things to this patient. And we get particularly concerned with thrombocytopenia. And this is where guidelines in the past had hard cutoffs. They would say really anyone below 10,000 platelets, automatic hold. Now, again, we're factoring in other things. It's a reasoning process. The big concern when someone has too few platelets is the risk of a spontaneous bleed. And if they bleed, we can't accomplish hemostasis, and that could create a very serious situation, especially maybe if they fall and have a bleed in the brain, or maybe even a hemoarthrosis, a bleeding in a joint. So again, interprofessional communication, determining whether a patient's appropriate, whether or not they're going to need to get transfused with platelets prior to mobilization. And if they are clinically stable but have severe thrombocytopenia, just being aware of potential fall precautions and taking measures to mitigate that risk. And next we'll get into coagulability tests. So we got three big ones. Our Prothrombin Time, or International Normalized Ratio, and our Activated Partial Thromboplastin Time, or APTT. Prothrombin Time and INR. INR is basically a ratio of prothrombin time from the patient compared to a normative value. So they're both kind of looking at the same thing. We typically use it to monitor the effectiveness of drugs like warfarin, or also known as Coumadin. APT are used to monitor the effects of heparin and heparin-like derivatives, so our regular heparin and low molecular weight heparin, or enoxaparin and Lovenox. These medications, you guys remember, will be given often post-cardiac surgery, stenting, or if a patient has a high risk for clots, like someone with AFib, or someone who has a mechanical heart valve, and patients who maybe have a DVT, they'll be given these medications to reduce the risk of subsequent clots and prevent the risk maybe of embolytic events. So prothrombin time, again, assesses the function of the intrinsic system. We're not going to get into the extrinsic system. This is a physiology course. Normal range for this, 11 to 13 seconds. Again, this is a fast system, so we should see blood clot within 11 to 13 seconds in our lab. Typically for patients with a clotting concern, we will give them medications like warfarin to lower the clotting ability. So we want to see the values for that a little higher, right? Maybe closer to 16 seconds, 18 seconds, right? We call that therapeutic. Values above 25 seconds, there's a risk for bleeding, right? Again, we're trying to some of these medications increase the time it takes for a clot to form to decrease the likelihood of clots occurring, right? So the longer it takes for you to create a clot, the higher risk you have for a bleed, a spontaneous bleed that does not achieve hemostasis. So again, always use your judgment with these patients. Now, what makes things probably easier, because again, remembering seconds or not, is this value, the international normalized ratio, which again compares things to a normative value to make labs consistent across facilities. Basically, what we do is take the test that we've done in this patient and compare it to a normative value, which is usually 12 to 13 seconds. And then we get a normal range. A normal INR, you can just remember, it's 0.8 to 1.0. It's typically a value of 1, right? So these are both 0.2 below 1, so 0.8 to 1.2. Again, therapeutic ranges, we're going to increase the time, usually double it. So for stroke prophylaxis, 2 to 2.5. DVT, pulmonary embolism, 2 to 3. Valve replacements, maybe a little bit higher. Patients above 3.6, right, higher risk for bleeding. There used to be old guidelines that would say anyone above a 6, you would automatically hold, or therapy would be contraindicated. Again, we just, the way we're approaching it now, anyone above 3.6, high risk for bleeding. Factor in other concerns and go by your institutional policy. Partial thromboplastin time we often see as the activated form, which helps speed up the process. So we use a slightly different value. This looks at the intrinsic pathway, or the slower system, and a normal range for this would be about 21 to 35 seconds. This is relevant, again, because APT or PTT, these assess the effects of heparin. So someone's given heparin, the INR is not going to be the value that we're going to look at for therapeutic effect, or whether or not a patient's appropriate. The APTT is. So again, values above that normal range is going to be a higher risk for bleeding. Our critical value for this is above 70, and much higher risk for a spontaneous bleed. Again, use caution, discuss with the team whether or not the patient's appropriate. Last thing we'll cover are Wells criteria. Again, just remembering these are something that you might want to be screening for in a patient who we think has a risk or has something from our initial assessment that makes us think a blood clot's present. We have our criteria here. Again, we covered this in the cardiovascular disease lecture, but just a nice reminder. And we have a similar scale as well for pulmonary embolism. I do want to talk about, there is a condition called Disseminated Intravascular Coagulopathy, which is a very serious blood disorder that we can see as well. You may see this in the hospital, DIC. This is what this means, is that you can see this in patients with cancer, with sepsis, where you've got these small blood clots form in the body and brain that kind of travel everywhere. They embolize, leading to multi-organ failure. What we often see, though, with this, the clotting factors in blood are often used up. So they have really high risks of bleeding, but they have these multiple clots. It's a very serious condition. You may see this in the chart, and you may wonder what's going on with these lab values. How do they have such a problem with clots, but their INR is super high? Well, it may be due to this condition. D-dimer, we talked about this in the pulmonary embolism, DVT parts of this lecture. This is often used when this is suspected, again, because when we see D-dimer, it's a measure of degradation product from the breakdown of fibrin, which again occurs when we're remodeling a clot. It's part of that normal physiological process. It will be elevated, right, when a clot or thrombus is present, or a PE. And it's also used to confirm the diagnosis of DIC. So someone's got really low factors in their blood, or really high coagulability tests, but a really high D-dimer makes us think maybe this DIC is present. So again, these are things that you may see often in the chart. So with that, that's our CBC, and then next we'll be getting into our BMP, our basic metabolic panel. Thank you.